I said the gonads develop posterior to that. Our kidneys are posterior to it. And they slide down behind it. So imagine, you know those advertisements where those pieces of dirt, people get taken up by the mop, all right? So imagine you're one of those pieces of dirt, you're sliding down the wall, and you get to this opening, this well, the inguinal canal, and as you're sliding down it, you grab the peritoneum, and you pull it down with you. Is it going to completely surround you like these are, forming the wall of that well? No, it's going to be in front of you, okay? So the peritoneum, I have a purple, wasn't working very well anyway. So the peritoneum comes in and is found only along the lateral aspect and the sides, not all the way around the testis. Okay, all the other layers completely surround and forming the spermatic cord, but not the peritoneum. So we'll label it peritoneum up here, but down here it forms the tunica vaginalis. You guys actually have two vaginas. This means evagination, an outpouch, okay? And so it's normally closed, but sometimes it's open to the peritoneal cavity, and serous fluid can flow down into the tunica vaginalis and create a swelling known as a hydrocele. So sometimes infants will have an enlarged scrotal sac, maybe just on one side, which is the excess fluid flowing into the tunica vaginalis. And a simple minor surgery, which is taking a syringe and taking that fluid out. They may need to do further surgery to stitch the tunica, the peritoneal layers together so it doesn't continue to reappear. All right, so those are the layers of both the spermatic cord and the testis, the scrotum. So on this diagram again, here is the opening of the inguinal canal. So the inguinal canal is specifically that channel that crosses over the pelvis and into the pelvic cavity, from the scrotum to the pelvic cavity. All right? And it contains not the testes, just the spermatic cord. So here's its opening on the outside, under the skin. That's known as the superficial ring. Okay? And then there's an opening on the deep side of the abdominal wall, on the internal surface of the abdominal wall, and that's known as the deep ring. So if we look at this diagram here, this would be the deep ring right here, where the blood vessels and the peritoneum go in, and the vas deferens comes out. So on our models, to find the deep inguinal ring, that would be located right here on the internal surface or deep surface of the anterior abdominal wall, right? And the superficial ring would be right here, not here, that's been artificially cut in the model, but up here would be the superficial ring, okay? Or on our sagittal models, you're not seeing the superficial ring here because the entire wall is gone, but it would be right about here. And then as you look inside, right there is where the vas deferens is passing into the abdominal cavity, and that would be the deep ring. Okay. Now in males, because of the presence of the vas deferens and extra blood vessels more than the female needs, the inguinal canal is larger in diameter. Hence, males can develop an inguinal hernia more likely. That's usually caused by a weakness in the abdominal wall, increased abdominal pressure, all right, from not lifting properly. And guys have bigger muscles, so they could increase the abdominal pressure more. There may be a congenital weakness in the abdominal wall as well. that would allow a loop of intestine to protrude into the inguinal canal. And that appears as a bulge, especially it may disappear when there's no pressure and appear back when pressure increases. All right, so a hernia is any weakness in the muscle wall. So a diaphragmatic hernia is a weakness in the diaphragm, and the stomach may bulge up into the thoracic cavity. An umbilical hernia is usually in infants. They cry a lot and create a lot of pressure. There's a weakness because that's where the umbilical vessels pass through. So there might be a mound or swelling of intestinal loops up into the remnant of the umbilical cord. So an inguinal hernia is a loop of intestines, ends up in the inguinal canal. It may actually come through the superficial ring. So we talk about or classify two different types of inguinal hernias. The direct inguinal hernia, I always had trouble with this because the direct seemed indirect and the indirect seemed direct. So let's say that that external wall of the room is the abdominal wall, okay? The doorway would be the deep inguinal ring. And I am a loop of intestine. What's the most direct, shortest route for me to get outside? Not the easiest, but the shortest route to go outside. Straight through the wall, okay? So I go in a straight line, bang, right through this wall, which I couldn't do unless there was a weakness there, okay? Then I would be in the inguinal canal. That's a direct inguinal hernia. So a loop of intestine, here's our inguinal canal, all right? That would be the deep ring right there. The loop of intestine passing through a series of weaknesses in the external and the internal obliques, enters into the inguinal canal. Here's the problem. That's a narrow space, especially if it twists. It can cause blood vessels to constrict, and that tissue can die and become gangrenous. All right, if it moves back out again, things are fine. But if it stays in there, and especially if it twists, then we lose the blood supply to that segment of the small intestine. So direct inguinal hernia is straight through the muscle wall, but it still goes into the inguinal canal. It would have to go through the side of the inguinal canal. The indirect takes a longer but easier route and actually goes through the deep ring. Okay? So here's an indirect. Both of them are in the inguinal canal, but here's a loop of intestine that is following the vas deferens by passing through the deep ring. All right? So the direct would have had it coming this way. Indirect going around this way. Here's a couple of blood vessels that branch off of the external iliac artery and supply the abdominal wall. We don't learn the name of them, but they help to diagnose. If the entrance is lateral to these vessels, that means it's going through the deep ring and it's an indirect. If the entrance is medial, then it's going the direct route and going through a weakness in the abdominal wall. Okay? All right, let's go back and look at the content of the spermatic cord again on this diagram. So we've talked about external spermatic fascia, cremaster muscle, dartos, which is in the skin, and the content. Content is vas deferens, okay, the tube that's carrying the sperm back up to the urethra. The testicular artery, which of course needs to, the diagram, the contents are listed again back on page 52. The testicular artery, which is needed to supply the testes. The testicular veins, which are carrying that blood back. But notice how branched they are, how reticulated they are. As such, they are known as the pampiniform plexus. And that's what I want you to identify them in lab. So in the spermatic cord, the testicular veins form as the pampiniform plexus. And the purpose now is not to keep the testes warm, but to cool them down. Okay. And this is to form a countercurrent heat exchange. Countercurrent meaning the blood flow is in opposite directions. Well, that's the case anyway. Arteries are going usually towards an organ and veins are going away. But by being very close to each other and by being branched, we increase the surface area that's in contact with the blood. So to illustrate a similar relationship, whales spend a lot of their time in the Arctic. All right, they're warm-blooded animals, they're mammals, and so their blood is heated. As it flows out to supply the tissue of the fluke or the tail, that's pretty thin relative to the mass of the whale. It's in contact with frigid water. With direct conduction, heat is easily lost into the ocean. Now that blood is very cold, and the venous blood is carrying this cold blood back to the core abdominal cavity, and it's going to have to be warmed up. And that's going to require the whale to expend energy to warm that blood up again. So to prevent that heat loss and subsequent replacement, as the hot arterial blood is flowing out to the fluke, it's wrapped around by the veins, coming in, carrying the cold venous blood, and heat is transferred from the arterial blood to the venous blood. Now, as the arterial blood is losing that heat, it's getting cooler and cooler, but there's still a difference in temperature because the venous blood that it's meeting is still very, very cold. It's just coming back from the fluke. And as the venous blood is almost to the abdominal cavity, it's warmed up, but it's meeting very hot arterial blood. So there's always a temperature difference, and thus an exchange occurring between the arterial and the venous as it moves along. And so the presence of a pampiniform plexus wrapped around the testicular artery like this is allowing that countercurrent flow for heat exchange, okay, and increasing the surface area of that. Okay, so this diagram here illustrates we're looking on the deep surface of the abdominal wall. So it's like we took the breastplate off of the model here. So I redid this once this morning. I know all the organs inside aren't going to come falling out. All right, so if we turn it around, here are those vessels that I said supply the abdominal wall. You can see them going up towards the rectus abdominis on that diagram. And so lateral to these vessels out here would be the opening in the pelvis for the inguinal canal. This is the deep inguinal ring. Here's the testicular arteries and vein and the vas deferens. So if we have a loop of intestine going in through there, that would be the indirect, lateral to these vessels. The direct inguinal hernia would be going right through here, through a weakness in these muscles, or medial, and that's the direct pathway. Okay? All right, any questions on that? We're going to look at the testes itself now. So on page 56 of your lecture notes, we have a couple of plasticized testes here. All right. This would be the surface of the testis, covered with a connective tissue coat known as the white coat or tunica albuginea. This would be the spermatic cord. Testicular artery's been pulled out, and the larger structure here is the vas deferens. Okay, up here. On this one, you can actually see some faint pink strands of premaster muscle. So you can take a look at those in lab. And now so here you're looking at the surface of the testes. Okay, this is part of the tube carrying the sperm away, the epididymis. So let's look at a larger diagram, and I'll diagram that with you. Remember when we were looking at the development, how the sperm cells associated into columns with these tubules? And these tubules are found in segments of the testes. So, what orientation do we have here? All right. So here's a connective tissue capsule. From that connective tissue capsule, bands of collagen fibers extend into the testes and divide it into segments, kind of like an orange, you know, with those membranes. Within each segment are 15 to 20 hollow tubes, known as the seminiferous tubules. There's only 2 shown here, and that's what I'll draw. They're highly coiled into hairpin, even more highly coiled than what I've drawn here. And then 2 come together to form a straight segment. All right? So this would be known as the single seminiferous tubule. And that is where we find our undeveloped sperm cells. This is known as a straight tubule, or in Latin, the tubuli rectus. You can use either term. Okay? Multiple straight tubules join together and form a branching network-like arrangement of channels known as the reedy testes. And that would be this region right here, right along the posterior wall of the testes. Remember our mesonephric duct and how it was associated with the testes, forming efferent ductules? So I'm going to draw that in a different color to show that it has a different origin. And these form a series of channels as well. And these are the efferent ductules, or you can use the word duct if you wish. And then all of the efferent ductules, these structures right here, join to form a single but very highly coiled tube known as the epididymis, continuing our mesonephric duct origin. Very highly coiled. Runs along the posterior aspect of the testis, and then curls back up. So efferent ductules. This structure is our epididymis, head. Body and tail. And then we begin our vas deferens. So if I were to write